Hi, I'm Ishola Agbaje, Medical Director here at TFP Belfast Fertility. I'm here as part of the Ask the Expert series, and we've taken some more questions from patients on social media, and I'm here to try and give answers to some of these this afternoon. So the first question we have is, I've heard about PGT, but I'm not sure if it's something that we should consider. Can you explain who's it for and whether it actually improves IVF success rates? P stands for pre-implantation genetic testing, and involves taking a sample of some of the cells from an embryo that are going to make up the placenta and sending them to a lab to get genetically tested. And this technique is sometimes used with people with a specific genetic disorder or who are at risk of passing a gene on to the next generation in order to try and reduce the risk of this happening. PGT-A stands specifically for pre-implantation genetic testing for aneuploidy. And aneuploidy is just another term for a chromosome abnormality. This is where the same technique is used to check that the embryo has the right number of chromosomes. And many embryos that patients produce won't have the right number of chromosomes, and that's often why embryos don't implant, or if they do implant, they result in an early miscarriage. Embryo quality is usually assessed by simply looking at an embryo, looking at how the cells look like, looking at how the embryo grows, and it really is a fact that you can't judge a book by its cover. Good-looking embryos may not be normal genetically. PGT-A allows patients to select out and only use embryos that are considered to be chromosomally normal. Whilst these won't implant 100% of the time, their implantation potential is better and they result in pregnancies with a lower risk of miscarriage. Whilst PGT-A won't make your treatment more likely to be successful, it does what we call reduce the burden of treatment. So it means that the time taken to achieve a successful pregnancy is likely to be shortened, and where you do become pregnant, the risk of miscarriage is likely to be less, particularly because most miscarriages are associated with chromosomal abnormalities. In general, we would recommend patients consider PGT-A in certain circumstances. For example, if they're older, perhaps age 38 and above, if they've had recurrent treatment failure or recurrent miscarriages in the past. So another question we've had is regarding the process of restarting treatment after a successful pregnancy and whether or not patients have to stop breastfeeding. I think it's generally recommended that women stop breastfeeding before fertility treatment. Breastfeeding and the hormones that it stimulates can affect the reproductive hormones, often inhibiting ovulation and perhaps influencing the lining of the womb and the chance of embryos implanting. In addition, some of the drugs used in fertility treatments may cross into the breast milk and may be harmful for any baby that is feeding. In terms of restarting treatment, depending on your individual circumstances and the treatment that's planned, you can normally restart fertility treatment within a couple of months of weaning your baby. Okay, another question that we've had is, I'm struggling with thin lining for my frozen embryo transfer and nothing seems to help. The clinic can't get my endometrium above 4.5 millimeters. Now, this is a common and sometimes very difficult problem that we see in the clinic, and it's probably true to say that there's more to the receptivity of the womb lining than thickness alone. In general, most clinics would like your womb lining to develop thicker than 7 millimeters, but this is a slightly arbitrary threshold based on old studies. Every patient is different, and for some women, the lining of their womb will never develop to this level. When faced with this issue, it's often about making sure that we achieve the optimum level of womb lining for that individual patient. So in other words, reach their potential. It's also important to rule out any potential pathology that could stop the womb lining develop and interfere with an embryo implanting. One of the issues that we look for is something called Asherman syndrome. This is where adhesions form within the womb cavity and can inhibit the development of the womb lining. In terms of moving forward with treatment, if we've ruled out pathologies that can affect how your womb lining grows, it's often about trying to maximize the development of your own endometrium, and we can do this by altering perhaps the dose of the drugs that we're giving you or the route at which they're administered, and sometimes we would use patches or vaginal tablets, and occasionally we will simply monitor the lining of the womb in a natural ovulatory cycle. There are some interventions that really don't have a good evidence base, but are commonly used in clinics. And this is not something that we would generally recommend, for example, Viagra or platelet-rich plasma infusion. More recent studies don't suggest a particular threshold below which a pregnancy cannot occur, down to quite low levels or quite thin levels of endometrium at around 4 millimeters. So although more studies are needed, As long as underlying pathology has been ruled out and we feel that we've reached the maximum potential for you, it's often worth proceeding with your embryo transfer. Another patient has asked, if you have a low AMH at around 1.5, age 31 in this individual, does that mean you'll go into the menopause early? AMH, or anti-Müllerian hormone, is a measure of ovarian reserve. A low level does not necessarily mean that you will have premature or early menopause, and women with a low AMH can continue to have normal cycles for several years. And actually, AMH cannot predict with any certainty when the menopause will occur. I think the main significance of AMH when considering fertility treatments and options is that AMH is a decision tool, and it helps us decide what to do, when to do it, how to do it, and helps us manage our expectations through treatment. Many treatments like IVF depend on our ability to stimulate the ovaries to produce a number of eggs in order to get a number of embryos in order to get a chance of a good quality embryo. And stimulation is likely to be more difficult and more limited in patients with a low AMH. So another patient has asked, does weight determine whether you can do IVF or IUI in our clinic? Patients' weight, or the more commonly used marker of weight, the body mass index, does not determine the type of treatment that you can do in the clinic. However, we do have a BMI limit. Although many clinics are different, here at TFP Belfast Fertility, our BMI limit for all fertility treatments is 35. So an interesting question that we've had from one patient is, what would be the leading causes of sperm not penetrating an egg during the IVF treatment? This is something called failed fertilization, and thankfully failed fertilization is rare in IVF, but nonetheless devastating for a couple. And it really can be divided into two causes, either sperm related or egg related. In terms of sperm-related causes, the first is failure of the sperm to bind to the egg. And the sperm has to bind to the egg in order to then start a reaction whereby it penetrates the egg. And this can be as a result of abnormalities with the proteins involved in attaching the sperm to the egg in order that they can penetrate and then fertilize. This is not something that you can actually test for, but in a way, an IVF cycle itself is like a dynamic test of that sperm's function. And the treatment itself can actually reveal insights where this is not working correctly. Poor sperm quality can also contribute to reduced or failed fertilization, and abnormalities in the sperm count, motility, or the way the sperm look, this is called morphology, can all contribute to lower fertilization rates or occasionally failed fertilization. This is something that's normally picked up prior to your treatment, and each clinic will have definitive cutoffs to where they either do IVF treatment or ICSI, whereby the sperm is injected directly into the egg. Egg-related causes include low numbers of eggs retrieved during the IVF process. When we think about eggs, the number of eggs that might fertilize in a cycle, on average, we would expect around 60% of eggs to achieve normal fertilization. When patients have low numbers of eggs, this can be very much an all or nothing effect. And if only 2 or 3 eggs are obtained, then sometimes none of them can fertilize, all of them may fertilize. So eggs have a shell around them, and this is called the zona pellucida. And sometimes abnormal hardening of this shell can mean that sperm find it difficult to penetrate and thereby fertilize eggs. Occasionally, eggs fail to be activated and undergo a series of reactions once a sperm enters the egg. This is quite a rare phenomenon, and there are some solutions within the clinic that your fertility doctor could talk about if this was the case. Finally, thankfully, it's extremely rare to have a laboratory issue that leads to failed fertilization. In most cases of failed fertilization with IVF, usually your fertility specialist will talk to you about ICSI being undertaken in the next cycle. Whilst this doesn't guarantee fertilization in all cases, it would help circumvent some of the problems that we've talked about. So one of our patients has asked, why is it getting harder for younger people to achieve a pregnancy? I think there can be several factors that contribute to the rise in infertility that we're currently seeing. And these can be divided into social factors, biological factors, and perhaps environmental factors. If we take social factors first, people are certainly starting their families later on in life, balancing education, career, and financial pressures. And age has a particular effect on female fertility. And what constitutes young in 2025 starting a family is certainly very different to several years ago. The average age today of having your first child is around 30, whereas this was 25 back in the 1970s. So people are often more open sharing the fact that they have difficulty conceiving compared to the past. So sometimes there's a greater awareness amongst patients and friends and family that people are struggling to conceive. In terms of lifestyle factors, rising rates of obesity, both in males and females, also contributes to poorer reproductive health. Use of tobacco, vaping, drugs can all affect both sperm and egg quality. And there's also increasing rates of sexually transmitted diseases, which can affect both tubal function in females and sperm in men. Environmental factors are a widely cited reason for a decline in both male and female reproductive health throughout the world, and increased consumption of highly processed foods and environmental pollutants can often disrupt reproductive hormones and affect our reproductive health. Sperm counts are known to have been falling over the last 50 years or so, and this is thought to be at least in part explained by these types of environmental issues. So one of our patients has asked, can I conceive using a sperm donor with my own eggs? I have regular periods. Well, the short answer is yes, you can conceive using a sperm donor at age 41, but it's important to understand the full choice of treatments, the limitations of each, and the associated success rates. Female age is a key factor in the chances of success from any treatment. The simplest treatment to undertake is something called intrauterine insemination, and that's where sperm, the donor sperm, is put into the womb at a time point either in the menstrual cycle or a stimulated cycle. And the odds of this treatment working in general at 41 would be low, approximately 5 to 10%, and essentially would approximate the chance of a spontaneous pregnancy in 1 month in a healthy individual of the same age. Depending on your ovarian reserve, IVF may be a more cost-effective treatment choice with success rates up to around 15%. Implantation genetic testing for chromosomal abnormalities can be used with IVF in order to reduce the risk of implanting an embryo with a chromosomal abnormality, optimizing the chances of success and reducing the rate of miscarriage. Chromosomal abnormalities in embryos will rise with female age. It's important to understand that it may require multiple cycles, generating a number of embryos in order to have a chance of having a normal embryo to replace. So a patient has asked an interesting question. I'm 26. Is this a good age to start IVF? And I think it's true to say, in general, the younger you are, the better in terms of not just IVF success rate, but the chance of spontaneous pregnancy or the chance of pregnancy with any treatment. However, in terms of IVF, if you are young, you're ovulating reliably, you have normal tubes, and your partner has normal sperm, then it's probably best not to rush into a treatment like IVF, as a spontaneous pregnancy could well occur, especially if you haven't been trying for too long. There are circumstances where IVF would be indicated even at a young age, and that is, for example, if you've known to have tubal disease, for example, endometriosis, or if there's a male factor, if you're freezing eggs as part of a fertility preservation program, if you've known genetic condition and you're using genetic techniques such as pre-implantation genetic testing to reduce the risk, or if you're a single woman using donor sperm, or in a same-sex relationship undertaking shared motherhood. Thank you very much, everyone, for sending what's been some really interesting questions in. Hopefully we've been able to give you some answers to these. If you have any further questions or worried about your own fertility, then please contact one of our TFP fertility clinics, where we can arrange an appointment for you to discuss these concerns in person with one of our fertility specialists.